Hi, my name is Kylie Chisholm. The case study question that I am addressing is question number 2, which states, describe how the condom use promotion programs align, or do not align, with at least 4 of the major constructs of the health belief model. Go beyond the specific determinants that the program planners assessed and look carefully at what they did in the programs themselves. Does the program fit better than this theory, or with another theory discussed during class lectures? With both of them, or with neither? Justify your answer. What are the issues, weaknesses with the intervention, and how would you do it differently? The health belief model is a health behavior change model developed to address problem behaviors that cause health concerns. A behavioral health theory is a combination of knowledge, opinion, and actions taken by an individual in reference to their health. This model has 6 parts to it. First one, perceived susceptibility. Second, perceived severity. Third, perceived benefits. Fourth, perceived barriers. Fifth, cues to action. And 6, self-efficacy. I will only be discussing the first 4 constructs because they were present in the earliest model, where the last 2 constructs were added to newer editions. The first construct I will be discussing is perceived susceptibility. Perceived susceptibility refers to a person's perception that a health problem is relevant to oneself and that a medical diagnosis is accurate. Individuals who perceive that they are susceptible to a certain health problem will engage in behaviors to reduce their risk of developing the health problem. Individuals with low perceived susceptibility may deny that they are at risk for contracting a particular illness. Individuals who believe that they are at low risk for developing an illness are more likely to engage in unhealthy, risky behaviors. In the condom use case study, perceived susceptibility about consistent condom use was determined by creating focus group discussions that were held among various groups of individuals in the target area to identify and evaluate their perceptions, beliefs, and attitudes for using or not using condoms consistently. The 4 common beliefs were: 1. Condoms won't burst if used correctly. 2. Condoms won't slip off if used correctly, therefore there is no need to worry. 3. No matter what choices you make, you always need a condom in commercial sex. And 4. No matter which sex partner you choose, you always need a condom. The second construct I will be discussing is perceived severity, which means even when one recognizes personal susceptibility, action will not occur unless the individual perceives the severity to be high enough to have serious complications. Individuals who perceive a given health problem as serious are more likely to engage in behaviors to prevent or reduce the health problem from occurring. Where individuals who perceive a given health problem as unimportant or not serious are more likely to engage in risky behavior. In the condom use case study, perceived severity about consistent condom use was addressed by educating the target population in small group activities such as games and condom demonstrations, street plays, and one-on-one and group discussions. The 3 found perceived severities were: HIV/AIDS is not a big problem in our country. Very few people get HIV/AIDS, and HIV/AIDS is happening only in big cities. The third construct I will be discussing is perceived benefits. Perceived benefits refers to the patient's belief that a given treatment will cure the illness or help to prevent it. The course of action an individual takes in preventing the illness or disease relies on consideration and evaluation of both perceived susceptibility and perceived benefits. If an individual believes that a particular action will reduce susceptibility to a health problem or decrease its seriousness, then he or she is likely to engage in that behavior regardless of objective facts regarding the effectiveness of the action. In the condom use case study, perceived benefits about consistent condom use was addressed through educating the target population on why wearing condoms consistently during commercial sex work significantly reduces the risk of getting HIV/AIDS. The fourth construct I will be discussing is perceived barriers. Perceived barriers refers to the complexity, duration, and accessibility to the treatment. Even if an individual perceives a health condition as threatening and believes that a particular action will effectively reduce the threat, barriers may prevent engagement in the health-promoting behavior. In the condom use case study, perceived barriers that had to be overcome were social norms of condom use, improving access to condoms, increased consistent condom use among the target population, and improving access to proper treatment for sexually transmitted infections, and create a demand for proper STI treatment. Theory model fit to the case study. The health belief model does not 100% fit the condom use case study due to its complexity, but there are features that could apply. Better model fits are the trans-theoretical model and the social cognitive theory. Trans-theoretical model is a behavior change that assesses an individual's readiness to act on a healthier behavior and provides strategies or processes of change to guide the individual. Trans-theoretical model consists of 5 constructs: pre-contemplation, contemplation, preparation, action, and maintenance. The condom use case study fits the trans-theoretical model. The use of small group activities and street plays promotes the slow process of behavior change among the constructs for consistent condom usage. Social cognitive theory examines the ideas that people learn by observing others. These learned behaviors can be central to one's personality. The interactions among persons and the environment that one grows up in contributes to a person's behavior, aiding in changing the social stigma of condom usage. Issues or weaknesses in the health belief model are that it is mostly focused on the individual level factors without considering environmental, community, and structural level factors. It assumes that people do a lot of thinking about health problems and conduct cognitive decision making. It also oversimplifies complex concepts. Given that the health belief model was used, I would personally choose to select a different theory altogether. Other models, such as the trans-theoretical model and the social cognitive theory, are a much better fit for the condom use case study. My personal preference would be to apply the trans-theoretical model to the condom use case study. This model assesses an individual's readiness to act on a newer behavior with a setup of the street plays, small group activities, and one-on-one and group discussions. This created a perfect platform for those passing by in the target areas to stop and participate in if they were looking to make this change. The program addressed the model's 5 constructs to begin the process of the actual behavior change. Here is a copy of my references. I hope you enjoyed watching my presentation, and I look forward to watching other group members' presentations.